Binder, you have the floor.
Cool. Well, thanks for this opportunity. And this is intimidating for me because I mean, people before were want to talk about new therapies, and Foxy wanted to sort of get back to basics. And when you start talking about basics, you guys are the experts, right? And so everyone has learned either from online providers, yourselves, your own experience. But to me, it's really important when thinking about, what are the basics and to think about new treatments and therapies. I think it's really important to have a background in terms of what's going on inside the body. Because then it gives a framework for like why one treatment might help with this or something else would make things worse and things like that. And so just to start off with, I've got some slides that I hopefully aren't going to feel too much like school. If anyone wants the slides later, let me know, you can have them. But just to give a background in terms of what's happening in your body and how some of the things you do to help sickle cell tie in there. And as always, reach out anytime after this with any kind of questions. So I want to go over some things that inside the body that lead to the sickling, and then try to link this to things that you do in your everyday life, which you know better than anyone else, and how that relates to what's going on in your body, and then link this to treatments. And so let's just start with hemoglobin. I think most people know it's what carries oxygen in the blood, and the red blood cells are full of hemoglobin. And hemoglobin is different parts. The first part is the globin, the blues and purples here, and their job is to hold the heme, these orangish rings. And the reason for the rings is they hold iron. And then the reason for iron is that's what actually holds the oxygen. And then it's important for therapy to keep in mind, whether it's gene therapy or any therapy, fetuses and adults have different kind of hemoglobins. In the fetus, you make mostly something called fetal hemoglobin, hemoglobin F. And then when you're adult, you make more hemoglobin A, okay? It goes way up after birth. And if you have sickle cell, instead of A, it's like adult, but it's got this change in it, but it only increases after birth. And the important thing is fetal hemoglobin doesn't sickle. It doesn't cause problems. So the more of it you have, the better you do. The more of it you have, the less sickle you have. So the goal is to increase fetal. And so as an infant, almost all your hemoglobin is fetal, and which is why infants don't usually have problems. And then in adults, the fetal goes away, and you have mostly hemoglobin A or hemoglobin S. So that one of the big games, name of the games in treatment, is to lower the sickle, raise the fetal. So what's happening inside of the red blood cell? Why does it matter that the sickle hemoglobin is different? Well, it carries oxygen just fine, but when it gets stressed out, it goes from floating around inside the red cell as little molecules to forming crystals. And that's when you get the change in the normal cells to the sickle shaped cells. And when they become sickled, they become sticky, which slow blood flow, and fragile, and they explode. And when they're sticky, they clog blood flow, which can lead to pain and stroke and other problems. And when they explode, that leads to the anemia and the yellowing of the eyes, the jaundice. So two different things. What people don't know or often don't think about is once you have a crystal, you can break it down. You can make it normal again. Okay, you can unsickle it. So our goal is to prevent things going from the left to the right and try to make things go from the right to the left. So the key thing with the crystals, sickle hemoglobin only forms crystals if oxygen is not bound. If oxygen is bound, you cannot get a crystal, you cannot sickle. And crystals take a long time to form. So the idea is low oxygen is bad, And the longer a red blood cell doesn't have oxygen, it's bad. So what we want is to keep the lungs open. We want to have enough oxygen. And then we need to keep your blood moving fast so that when they let go of oxygen, they get back to the lungs where they can get oxygen again as fast as possible. Okay? And then we want to decrease the amount of sickle hemoglobin and raise fetal. So in terms of oxygen, what are the risks? One of the big ones, and this is the real basics, it's not breathing deep. And a lot of people just aren't aware of it, but when people are in pain, they don't breathe deep. So when you're in pain, you don't breathe as deep, you don't get as much oxygen, it makes things worse. Infection, asthma, smoke, they all can get in the way of oxygen. Okay? Altitude, whether it's in a plane or driving over the mountains, oxygen levels go down, so that's a risk. Or if oxygen just isn't bound to the hemoglobin well, that's a risk. So what helps? You guys, I'm sure all know this, deep breathing, incentive spirometry. Boy, all the staff in the hospital know I go crazy about incentive spirometry to, especially when you're in pain, to open up your lungs. Pain control. It doesn't make sense to have people tell you to breathe deep if it hurts to breathe deep. So you need pain control. And then being active helps open the lungs. Infection, I mean, everyone tries to avoid it, but it's antibiotics when you need it, asthma medications, and I should have had it down, smoking. It just is hard on the lungs. Altitude, really the big thing is awareness of it, planning for it. And while you may not be able to change the altitude, you can optimize other things in terms of staying warm, hydrated, things like that. And then in terms of oxygen not being bound well, one of the drugs we'll talk about, voxelotor or oxybrita, the way it works and some of the new drugs coming out work is it helps oxygen stay bound to the hemoglobin. So I said we also want blood moving fast, right? We want it moving fast to get the red cells from the lungs get the red cells back to the lungs for more oxygen. And the blood vessels are like hoses. We want the hose wide so it carries a lot, and we want it open without any clogs in it. And again, we want less sickle hemoglobin in it. So I'm sorry that this is so primitive. I made this like 20 years ago. But what happens? Red blood cells normally zoom through the blood vessels and everything's good. They don't sickle. But white blood cells are big, slow, and sticky. So because they move slow, the red cells get stuck behind them. So they get stuck without oxygen, so they have more chance to sickle. So it sickles. When it sickles, it becomes sticky, which slows the blood flow even more. So the next red blood cell gets stuck behind that without oxygen. So the crystals form and it sickles. And then pretty soon it's all clogged up with sickled cells. You're not getting blood flow, and that's what leads to, occluding, vaso-occlusion, that leads to sickle cell pain. So it's all about keeping the blood flowing, keeping the white blood cells low with hydroxyurea. It's about hydration. It's about warmth locally in your whole body. And it's about getting up and moving, not just sitting on your butt. So how do you keep the hose wide and the blood moving? Well, the downsides are cold, like you guys all know. So what helps? Protecting from the cold, warmth, clothes, shower. Change the temperature in your hospital room. It was a big fight at Children's to get them to automatically turn up the temperature because a lot of the rooms are just cold. And then learning to minimize exposure, especially cold days like this. Dehydration, it's straightforward, right? It's bad. Fluids. more and more people know that stress actually makes blood vessels smaller. So anything you can do at any level to decrease stress is helpful. It's important that anyone that prescribes or medications, or when you take over the counter medications, you know what they do or check, because a lot of drugs and medications can change blood flow. Caffeine makes blood vessels smaller. A lot of migraine medicines make blood vessels smaller. And boy, when I hear someone's using cocaine, I get scared to death, because what's that do? It just makes the blood vessels get really, really small and really sets you up. People with sickle cell trait have had pain episodes, if they're using cocaine. And then the other part is move your body. Keep that blood flowing. It has to get out to where it needs to go, and it needs to get back to your heart. And you don't have to be like an expert athlete, but just moving around. And if you're lying on the couch doing video games, get up, move around, don't just stay in one position. So these are the basics. So what about clogging the hose? So one of the big problems is the white blood cells. As I said, they're big and sticky, and you have more white blood cells in sickle cell. But there's also blood clots and platelets in the blood. So what helps? Well, avoiding infection, because when you have infection, white blood cells go higher. But this is where one of the ways hydroxyurea is so important. It lowers the white blood cells. We want the white blood cells down so blood moves better. And then one of the drugs, crizolizumab or Dacvio, it doesn't change the number of the white blood cells. It just lubes them up. It makes them less sticky. So, when I showed it moving slow, it moves through a little more easily. And in terms of blood clotting, that's why we don't want people with trauma. No one likes trauma, but, tackle sports, severe contact sports, that's why we don't want people playing, rugby, tackle football, because when you get hit, your blood starts to clot, the platelets start slowing blood flow, and that's a great setup for sickle cell. And then there's also some medications that can help with that. In terms of lowering the amount of hemoglobin, the sickle in the blood, what helps? Or, it helps to make less sickle. It helps to make hemoglobin that isn't sickle. So making fetal hemoglobin or other types of hemoglobin, those are good things. Less sickle, more other types. Or anything else that makes it so you have less sickled blood cells and more quote unquote normal blood cells. Or it would also help if you just, instead of making sickle cells, you made normal red blood cells. So how do you make less sickle? Well, again, hydroxyurea. That's one of the big things it does. Also, one of the types of gene therapy, the V is for Vertex, it leads to making less sickle. How do you make more fetal or other hemoglobins? So not only does hydroxyurea lower the sickle, but it raises the fetal. And then again, that same Vertex gene therapy increases the fetal hemoglobin, which is the main way it works. And then in terms of raising and increasing other hemoglobins, Bluebird, the way that gene therapy works is by adding another hemoglobin that isn't fetal, it isn't normal, but it works great and it helps prevent sickling. How do you have less sickled blood cells or more normal? Well, the big thing is transfusion. And that can either be direct or straight, where they just put it in, or exchange, where you take blood out and you put fresh blood in. And then the last thing is, how do you make more normal red blood cells? And this is where stem cell or bone marrow transplant comes in. And that can be from a matched brother or sister, or from a stranger, or from a parent. So I just sort of want to end here, but these are the FDA approved drugs down below in transfusion, and just to compare and contrast. And I don't want to go over all of it. We can talk about it as you guys have questions. But so, for example, what are things that affect sickle cell? Well, you want to have more hemoglobin. You want to lower the S. You want to raise the fetal. You want to lower white cells. You want to make white cells less sticky. And you also want to keep the red blood cells from exploding. So some things are very specific. The Dacvio, it's really focused on making white cells less sticky. It does it great, but it doesn't do anything else, right? You know, voxelotor oxybrita, it only does one thing. Well, it does two things. It raises the hemoglobin, so you've got more blood, and it helps keeps the cells from bursting. And then there's other things like hydroxyurea that, you know, this is why we love it so much. It raises hemoglobin, lowers sickle, raises fetal, lowers white cells, makes white cells less sticky, and helps prevent them from popping. So with that, I'm going to stop, and whatever is helpful to you guys, you know, let's just take it from there. And I don't know if I should leave this up for questions about this or take it off, whatever is good for you guys.
I have a quick question about this.
Yeah.
So if you offer people glutamine and Endari and there's no benefit to it, why are people taking it? Because it looks like to me, with all those zeros and a question mark with the makes white blood, the less sticky white blood cells, why are people taking it?
Endari's an interesting situation. This is only showing how it acts in the body. This isn't saying whether it helps or not.
Oh, okay.
So it has been proven to help. Okay.
Help
and,
what?
And what? It helps
Help.
decrease. It helps decrease pain and going to the hospital.
Okay.
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 Endari, I actually give full hour lectures to groups on this because it's really interesting. They started doing it because they thought it would help protect red blood cells and help them be healthier and not explode. But it doesn't change red blood cells at all. Personally, I think they've missed the point. I mean, it works. I think it really works on white blood cells and other things. So it does work, but it doesn't fit into the simple framework I have here.
Okay.
Yeah, because it's interesting. If you look at this, you feel like, well, hydroxyurea is the only one that's pretty beneficial, transfusion some, but the rest are kind of like, yeah.
So you have to be careful, Peggy.
Okay.
This is just about how it works to raise hemoglobin or lower sickle. It's not saying anything about how much it helps a patient's life.
Okay.
So, but yes, hydroxyurea kicks butt. You know, absolutely. Okay. But one reason for looking at it is as there's going to be more drugs, there's going to be more drugs coming out that make white cells less sticky. There are other drugs coming out that raise the hemoglobin. So when you think about it, it wouldn't be smart to be on oxybrita and another drug targeted at just raising the hemoglobin. But if oxybrita is enough, maybe something like a Dacvio, you know, because it does something completely different. So you have two different things going on. Right?
Yeah.
Yeah, but then I still look at hydroxyurea, and I mean, that seems like for the purposes of this, of what they will do, that would be the only drug that you maybe would need. You wouldn't need all these other ones.
Yeah, people have.
Next time
but then I guess you would need it for other things. I guess if I'm just looking at this chart, that's just confusing to me. Yeah, I have to.
next time I see you, Peggy, I'm going to buy you a drink. Okay? But I am so with you. This
I'll
is
need a few, I think.
this is why we push hydroxyurea, and it's the only one we recommend starting at 6 to 9 months of age, and why it's always an approach of start with this and then add other things,
Okay.
right?
Okay.
So I'm so with you, Peggy.
Now,
And I have a
a
question on
with
this.
this.
Hold on, you guys, John,
hydrox-
I'm sorry. John has his hand raised for a while.
Oh, okay.
I just don't want to miss you, John, so you might just have to come off on mute and then say your question, John.
Oh, it's okay. They were having a good conversation. I think my call out was, I shared the same call out for Peggy reading hydroxyurea. So I guess if what we're seeing here is how how it functions in the body, how do we measure the efficacy of it? Like, how do we know how effective it is? Because based on what we're looking at right here, it's how the functionality of the body, right? How these drugs work in the body. But how do we know how effective to the point where we can say, you know what, at this point, I think hydroxyurea, based on what we're seeing here, is the only one that kind of checks off all the boxes. But for the others, like Andari, and maybe even Veloxator, where's that balance where you can say, oh, this is how it works in the body, but then this is how we measure how effective it is to the patients that take it. Does that make sense?
Absolutely. Because, I mean, look at how it was decades and decades that everyone in the US was using Tylenol, but no one knew how it worked, right? I mean, if you've got sickle cell, are you more concerned about how it works or if it's helping, right? So no, you're spot on. And for me, I didn't go into all of that here because I was, told this was not so much about the new drugs, but just to open the door. We can talk another time about the drugs and what they've been proven to do. Okay. But in brief, if you're on regular transfusions and you do it well, okay, it almost completely stops pain, prevents strokes, prevents lungs problems. It's amazing because essentially you don't have sickle cell in your blood. Hydroxyurea, if you take it the way people recommend, which is not just one dose, but you keep going up until you're getting as much as your body can handle. They're doing this in trials in the US. There's more trials in Africa on it, but it dramatically decreases pain. It decreases stroke. It decreases the need for transfusion. It decreases days in the hospital. And how well it does depends in part on you and how aggressively you go up on the dose. The Voxelotor, the Oxybrita, it's great at raising hemoglobin, and that's nothing but good. It prevents a lot of potential problems. And right now they're in the process of actually following patients and asking, how much does it help pain? How much does it prevent stroke? How much does it prevent pulmonary hypertension? Some of these other things, but that's going to take time. So, when you get FDA approval, they do studies asking a specific question, right? So like for Dacvio, it was about pain, right? But it wasn't about overall quality of life. So it just takes a while for people to sort of follow people and get information. And this is one reason it's so important for you all to be on clinical trials, is because that's the way you find out by seeing, okay, let's say you've been on glutamine for 5 years. How are you doing compared to someone that's not?
Right.
Does that answer it, John?
Yes, it does. It does. And I think maybe my only other question is just a follow-up that just came up. Like, yes, you can still go up with your hydroxyurea, but then at what point does it is there a point where you plateau and say, okay, this is where the person's ability, this is how much the dose they could, and then this is how much they're actually able to function. So I guess maybe my request is like to see like some data moving forward. Just maybe data is there where we can find out like what's the maximum between the moment you start taking it to the point where we actually start seeing where patients are like, you know what, I'm not even getting any more sickle cell crises because I've reached at this dose, or in this how long it's taken me. That's the only thing I'm curious about.
Yeah.
So that is a really, really critical thing, but it's also highly variable. And honestly, I think you've really set up what I think one of the huge problems is. Because like hydroxyurea, if you work with your provider to every 6 to 8 weeks go up on the dose until you're at the most, usually in 4 or 6 months, you're sort of at the peak and it should start kicking in. A lot of people don't want to go up and they're on it for years at a low dose and it's helping, but not much. The other big thing I think speaks to American society is hydroxyurea is great. It is not perfect. People tend to still have some pain. Often they're still hospitalized. It's not perfect, but it's a lot less. And so because it takes a while and it's not perfect, people say, it's not helping. I still, had a pain episode. I still went to the emergency room. And it's hard looking at the big picture, as opposed to taking oxycodone, where it's working within minutes, right? And it's consistent. So it takes a different mindset. It's really about asking, how am I doing this year compared to the year when I wasn't on it? Does that make sense?
Yeah.
Absolutely. Thank you. It does.
All right, Jean, I think you had a question.
I did. I just don't know how to put my hand up there like that. So I've been looking out over
so
my
that's
screen.
I figured that. So I just let me
Okay.
pause and I heard your voice. No problem.
Oh, I'm
And
sorry. I
please,
didn't know
and
it's on.
everyone, please, this was just a launching. We wanted to make sure everyone had the basics of understanding, but also if you have questions in general, we are very aware that, the gene therapy is becoming a conversation. We did tell Bender like, hey, I'm sure you're gonna get these questions. So I just we're opening the floor. Just be thinking about whatever questions you have. Right now, after Jean, it looks like Amna and then Ken is in that order.
And we can do sessions on any other topics, right? As questions come up, right?
Yeah, absolutely.
Well, my question is, I know hydroxyurea is the first and the longest on market for treating sickle cell anemia. And I remember the doctors at the university who did this. My late husband was one of the clients that they tested and developed this drug with, so I'm very familiar with it. My question is, on the long term of any drug, is there additional side effects that start to happen from the use of drugs? It might be happening with one thing, but is it causing something else to happen within the body that could be towards the negative? I know one has to outweigh the other, but are you aware of any specific long-term side effects from hydroxyurea?
Yeah, so that is a key thing. And again, that's what, this wasn't set up to go over all the benefits and all the side effects.
Oh,
Those are
yeah.
really discussions you need to have with providers, or we can do another session. But any of these, they have, the potential benefits and they've got the potential risks. The biggest risk with hydroxyurea is if you take too much, it can lower the white blood cells too low or other blood cells too low.
Right.
Okay. And that's why people do regular blood tests to make sure that the white blood cells are still in a good range. That is the biggest thing. Okay.
Okay, because I heard at the beginning that a side effect could be possibly leukemia. Is that still
No, no. So thank you for bringing it up. And you still see a lot about that online. They have looked at that so much. I think some of the problems are, there's two problems. One is hydroxyurea was used originally for a lot of patients that had pre-leukemia. Okay. And many of those patients went on to have leukemia. So then people started looking at it and saying, well, maybe hydroxyurea was leading to the leukemia. But, this, I'm not talking sickle cell. I'm talking, they were using it for a different reason. But those people were, already destined to likely have leukemia anyway. The other thing is people noticed people with hydroxyurea tend to have more leukemia than other people. And so then people said, wait, they're also on hydroxyurea more. So maybe that's it. But there has been no suggestion that hydroxyurea increases the risk. And in fact, there's some suggestion it might lower the risk.
All right. Thank you. That answers my question. Thank you.
Thanks.
All right. Amna?
Okay. What do you want?
Dr. Bender, my question, Jane, she asked my question. Actually, I was asking the side effect of the hydroxyurea. Since it's working well with my daughter, but sometimes I have seen side effect. May this come with the time or because of the increased hard doses? This is my first question. And the second question, the gene therapy. Is the gene therapy as something to effective for sickle cell who are really having a lot of crises, or someone who have been really like doing well with the sickle cell, it can done this therapy? It have been approved like for everyone now or not yet?
Two great questions. So first, with hydroxyurea, there are other risks, okay, or potential risks, okay? One of the ones that's really common is it can irritate your liver. And when I say irritate, you can't tell, but if we do a blood test, it just shows that something's irritated there. Is it bad? Usually, it's very unusual for it to be a factor or problem. The main time it's a factor if someone is on multiple medications that are hard on the liver. So hydroxyurea in healthy kids, it's not an issue. But if you're an adult on a bunch of different medications that are hard on the liver, that can be an irritant. But then you back off the hydroxyurea and it gets better. The other, it's not a long-term side effect, but a short-term side effect of hydroxyurea is it does lower sperm count. It doesn't, or it can. It doesn't change sexual function at all. But we don't want people on hydroxyurea having babies while they're on it. We always suggest stopping it beforehand. And when people stop the hydroxyurea, the sperm count comes back. But the amount of fluid, the sexual function, that isn't altered. It's just the number of sperm while you're on hydroxyurea can go down. In terms of the gene therapy, the way the FDA works and drug companies works, to me, is sort of nutty. So when they test a medicine and do the trials, they don't just test it on everyone. they do it on a very, very select group of people, right? They are looking closely at their age. So like for sickle cell, the age, what form of sickle cell, how many pain episodes they've had before, whether they've had strokes before. They tightly define that. But then when they approve the drug, they just say for sickle cell. So for the gene therapy trials, they had a very, very tight, restricted population. You know, you needed to have a certain number of pain episodes, but not too many pain episodes, you know, things like that. When they approved it, it just says for sickle cell. They don't say anything. So when you say, you know, for a healthy child, for a sick child, the reality of it is, if it's a medicine or a gene therapy, the person prescribing is responsible for looking at the risks and benefits and saying, yes, this could help, but the risks are so high, it's not justified. And that they should have that conversation with you as well. So in the real world, right now, they are not going to do gene therapy. I would not trust any institution that did gene therapy right now on someone that's not had complications. Okay. With time, it'll move that way, but that's the way medications work. They're going to start with people that have had more problems, but aren't too sick. It's really tricky. They're going to do gene therapy on people that have had multiple or are having multiple complications, but not too many complications. And as they get better at it and things are smoother, they're going to start saying, it's going so well, yeah, we're going to take more people with very few or no complications. And as they get better, they'll say, oh, and we feel comfortable doing it for people that have had a lot more complications. So they always start in a middle zone. Does that answer your question on that?
Yes, it does. Thank you so much.
Ken, I think you're next.
Thanks, Bender, for answering these questions. And my comment is about hydroxyurea. And I was in the clinical trials on hydroxyurea, and that was 30 years ago. And to your point earlier, the effects weren't instantaneous. It took me about a year to really realize the benefits of hydroxyurea for me. And like I said, it's just for me. For others, it probably will be different. But it is also a drug that has been studied for the longest amount of time. So there's a lot more data around that and hydroxyurea than there is for Valoxator or Oxbryta. So I'm really interested in seeing, you know, more information about the Valoxator and Oxbryta and the other drugs that are coming up as well, because I really think that this is a great time for sickle cell research, and I just really need to get more data about these others as well. So that's just kind of my information about hydroxyurea, how it works for me and how it's been positive. And I'm on the Oxbryta as well. And I'm still trying to understand if I feel different on the Oxbryta than I do with the hydroxyurea. So that's just my comment there.
So thanks for all that. A couple of things. With the hydroxyurea, it is a challenge for a lot of families to keep going up on the dose, because they say, well, wait, you know, my kid is doing fine, you know, or I'm doing fine, why should I go up? but the higher you push it, when you push it to the higher the fetal hemoglobin goes. And you can get fetal hemoglobins up routinely around 30%, which is the level where it's really, really hard to form any sickled cells. But it's about being disciplined and going at it, you know, and working with your provider. What I would love setting up is in Cincinnati, they figured out a great test. Before someone starts hydroxyurea, they take a blood sample, they give 1 dose of hydroxyurea, and then they do a blood draw like an hour later and like 6 hours later. And from that, they can calculate what they think the best dose of hydroxyurea for that person's going to be. So it could potentially skip a lot of that time of going up and up and up and just start up right up at the higher dose. So that would make it a lot shorter. The other thing is, I think it's really wise to look at how long of a history we have with different treatments. And while everyone is getting all sexy on gene therapy, bone marrow transplant, we have so much more data and so much more information, right? And for people that don't have a brother or sister that have a match, using a parent can work really, really great and have a lot more history with it.
John, is your hand raised again?
Oh, whoops. I was trying. I was
Nope.
trying
Can I add this question to that, please?
oh, I
Is
was
the hydroxyurea the increase like in depends on the kid's weight, or like how we have been doing with the hydroxyurea itself?
I love that question. What people have shown is the best way is you start with the dose first, just on weight, but then we look at you or your child and we look at what it does to your blood. We watch how much it lowers the white blood cells and changes some of the other things. And if the white blood cells have not come down, or they've come down and they're still way above the safety zone, we keep going up. And some people, you do it the first time and they're at the perfect dose, but others you have to keep giving more and more and more to bring the white cells down lower and lower and lower. So it's not based on weight as much as, you know, you or your child and how you respond to it.
Hey, Ben.
Okay, I have
Oh, go ahead.
this is Kendra Horn, Sleepy. And I'm on all of these ones that are listed. I take all of them. And recently I was hospitalized for about a week and a half. And I had missed some doses of the Oxbryta. And my doctor was saying how it was basically like my body crashing. So if you abruptly stop these medicines, will that send you into a crisis?
Love that question. So first of all, looking at it, it's combination therapy. Some have been proven to be helpful, some have not. Some don't make sense. Like it wouldn't make sense to be on Oxybryta and transfusions at the same time. Okay. But in terms of crashing, honestly, we have limited information. Okay. The problem with clinical studies, it's not a lot of people, and they often don't look a lot at people stopping. And often problems like crashing with stopping happens, for other medicines and other diseases, it doesn't happen right away. And it isn't real common. So we don't have a lot of experience. With hydroxyurea, if you stop, it does start increasing the white blood cells again, and people do start having more problems, but it's not a sudden crash. The voxelotor, I would not expect it to lead to any kind of sudden change because it's helping your red blood cells live longer, and the ones that already have the drug are sort of protected, and so they're going to be protected for a while. So it's a tough question, and I think with most of them, I wouldn't expect a sudden badness, a crashing, but could it happen? Possibly.
Okay,
Hey,
thank you so much.
Bender, I loved your comment about everybody's getting sexy about gene therapy. Just a question around what happens between, all the news around the therapy, gene therapy, and it actually being something that's accessible to, anyone in sickle cell, who has sickle cell, like I know you can't say exactly, but like the years between that, I'm imagining with hydroxyurea, when it initially started, everybody couldn't get it, but eventually now it's something where it's accessible to all. Can anyone who just says, oh, I'm now want to do gene therapy, it doesn't mean that I can just go to my doctor and all of a sudden I can get this therapy, I'm assuming.
Yeah, I love that question. I think it's a critical one. Believe it or not, I've got one or two soapboxes I like jumping on. And, backing up, I started working on gene therapy, in graduate school. That has been like a major thing of my work all through my life. I am so excited. I'm a huge fan, but we need perspective here, about it. Things are going to take a long time to get going. So there's two parts to it. One is if someone says right now, I want gene therapy, how long? And the other is how long until everything's set up so that everyone that wants it is able to get it. If you are on the clinical trial, the time from when you say, I want to get started to when it gets done is often over a year. It can be a slow process. In terms of centers, all kinds of centers are interested in it, but it can take many months to over a year for a center to get set up for it. Then the other thing is what happens is you go to a center, and Seattle could be a center, and they get your stem cells and then they send them off to the company. They fix them up and they send them back. How many of those treatments can a company do in a day, a week, a month? That isn't high yet. So when people are talking about it, they're thinking that with the gene therapy in the first year, it's probably going to be about 10 to 20 people, maybe 40. That's out of the 100,000 in the United States. So it's going to start really slow.
I would raise my hand right now, but my computer died, so I ran down to Kendra's. So with that information, There be a priority on who gets it? Young, old, less, more, sickle? Will there be a priority? This is Peggy, sorry.
Yeah. I love that question. No, it's a good one, right? Because for any limited resource, who has access,
Right,
right? And I think there's going to be a couple of levels to it. One is at first, they're really going to be screening because they want it to be a success and they don't want to do harm. So it's going to be for the people who have the best function of their organs, but still having lots of pain. So for example, if someone has, you know, 4 pain episodes a year where they're in the hospital, but their brain, heart, liver, spleen, kidneys are all working great, that's someone they would jump on more than someone that has had, you know, 1 or 2 pain episodes a year, and they've got some serious lung problems and kidney problems. Right? And so it's going to be sort of figuring these things out and balances. And it's going to be up to each institution to have their priorities. The other level is, I mean, I'm so glad you've got that session going on SSI, is it's a whole new world in terms of what's going to happen with insurance companies. And that's another one of my hats, is looking at the health economics of gene therapy and all of that, and models for how it's going to be paid. And I think with that first one, how much sickle cell impacts your body, I think that is going to be more equitable. Where my worry is, some people are better at knowing the system and working with insurance companies and lobbying for things and making things happen. And I think they're gonna, you know, get in more easily than people that, you know, have a hard time doing that.
right. And don't have the support to do it, to help them through that process, yes.
Now, honestly, centers are gonna be taking that on. And
Uh-huh.
it's the ugliness of the healthcare system. Centers are gonna be helping people because they make a lot of money from this. So it's good for them to help people get, you know, get approved so that they can make money doing this.
Hmm. So crazy. This is all crazy. So I'm sorry. I'm just like totally I don't know if do people have their hands up and stuff? Foxy, I can't see. Huh?
Ken has his hand up.
Okay. Tell me when I can ask a question, because I can't see what's going on, please.
No worries. You can go right after Ken unless someone else wants to throw in. You're totally fine.
Okay, so my question has to do with stem cell transplants versus gene therapy, and the, you know, success rates given the therapies.
It's an important one, and this is one of the hard things about gene therapy. For stem cell transplants, there are multiple types, right? There's from a brother or sister, that's a perfect match. There's unrelated people, and there's from a parent. And how successful it is also depends on your age. The younger you are, the smoother it is. The older you are, the riskier it is. And so if anyone goes and talks to a transplant group about their results, it shouldn't be about for the whole center. It should be people of your age and your background with your kind of transplant. So the other issue is, if you look at all types of transplants, they've done several thousand. With gene therapy, you know, it's like 40, right? With transplants, there are people that are, you know, over 30 years out from transplant. With gene therapy, there's a couple that are like 2 years out. Most are, you know, under a year and a half out. So it's really hard, you know, knowing in terms of comparing. If you look at success the first 1 or 2 years, the gene therapy is really amazing. Transplant is, you know, as amazing, except there's more side effects with the regular transplants. So it's, yeah. So depending on how you look at it, the gene therapy, almost all serious pain episodes went away. And I'm wording things carefully because the big Bluebird study did this, to me, garbage distinction, where they had major pain episodes, severe pain episodes and not severe. And it only counted as severe if you were in the hospital for over 24 hours. So if you went to the emergency room, went home, and were in horrible pain, that wouldn't count as severe. But those pain episodes go almost to zero. Almost to zero. With transplant, same thing happens. But it also doesn't, in both cases, it doesn't happen right away. It can take a while for them to fully stop. The more chronic pain you've had, the longer it takes. Because as you guys know, chronic pain is totally different. That's more about how your body's wired, not damage to your system. Okay? So if your body is wired to feel pain, even if there's no damage, when you get gene therapy or a transplant, you're still wired in a bad way. And that's going to take, you know, a year or two to sort of get normal again.
All right, Peggy, you want to go for it?
Actually, that was my question, Ken. Thank you. But from that, I guess, so is the therapeutic, is the gene therapy as, I mean, as far as recovery from both of those, the long-term, you know, recovery from it, both the same, but have, you know, so with bone marrow, you know, it's what it takes so long to recover, and you go through extensive other treatments and everything. So is there a big difference in that between the two of them, or are they the same?
It's very it varies a bit on the exact type of transplant. Some of the transplants recovery is quicker, but then with the transplants, there's also the chance of graft versus host and complications related to that, which happen. So you may bounce back a little faster with a regular transplant, but the recovery from gene therapy may be a bit easier. But there's so few done. It's, you know, it's really hard to say. We just need more information.
Thank you.
All right, Amna, I see you have a question.
Yeah, with the main difference, you say with the gene therapy, they fix the DNA itself, and with the transplant, the bone marrow, like they just, I think they change the blood or something. Is this like later on will affect like the kid's future, like the kids or the patient kids generation for both of them? Is it is count as different between both of them? Am I clear?
So first of all, there's many types of gene therapy. Okay. None of the ones that are FDA approved right now fix the sickle cell. Both of them are other ways to sort of stop having problems. So in one of them, you make more fetal hemoglobin and less sickle. And that's why it helps. You still have the sickle cell gene, but you still make sickle cell protein, hemoglobin, but you make so much more fetal, it's not a problem. In Bluebird, you don't fix it either, but you add another hemoglobin so that it's more like sickle cell trait. And in terms of long term, that's the issue. We don't know many of the things that are, going to happen over years, or if there are long-term complications. One of the big complications with most of the gene therapy now and of the transplants now is they impact fertility. And so it's really important, as soon as people start talking about transplant or gene therapy, to talk about options. But for long-term effect on fertility is big for both. And a lot of the research right now is looking at better ways to do gene therapy and transplant where you don't affect fertility.
Well, thanks for that, Bender. It's important to understand that these gene therapies are therapies and not cures.
So the hope is, it'll be a cure. There's actually a bunch of us nationally that are pushing to call gene therapy transformative therapy. That's going to revolutionize things, and it'll provide short-term benefit, but we don't have the long-term knowledge yet in terms of benefit.
All right, does anybody have other questions? This has been so informative.
Yeah.
Hi, Omar.
Oh yeah, I'm done. Hello.
How are you doing, Omar?
I'm good. How are you?
Good.
Oh, I didn't know that I was not on mute. Sorry.
No problem. I didn't know if you had a question.
No, I think all my the question that I wanted to ask, somebody asked them, so I'm good.
Okay, good.
How-
I'm gonna just pause and do a little bit of announcements, just because I know there are more people on. If you still have questions, you can hold them and think about them. We can definitely, it's like, what time are we? About 20 after. So again, thank you so much, Dr. Bender. This has been so informative, and always just appreciate the way that you're willing to come and make sure that folks are educated around sickle cell. Thank you for all the work that you do in this community and have done. So it's just a joy to have you. Also, just a few announcements. January 20th is our New Year's party. We are excited. We hope to see everyone, as many people out as possible. It will be at the Lakewood Seward Park Community Center. If you have not gotten information about that, please let us know. We will send that to you directly. You can just throw your information in the chat. We are doing a little bit of a potluck this year, which we haven't done in a long time. So if you have a favorite dish that you like to make, please bring it out, share it with the community. And the task force will be also providing some food in addition. So super excited to have as many folks to join us. And then let's see, February February 21st is our next education series, and it's going to be a specialist coming in to talk about Social Security and disability. So if you have questions about those topics, I know that there's been questions in our community for a while, and we're really excited to finally have a specialist to be able to come and answer those questions directly. So please bring your questions. If you know others who need to be on this call, if you know others with sickle cell that maybe don't even live here, but are just trying to navigate this system, they are more than welcome to join. And then February 24th is our gospel concert that we do every year. This will be the 9th annual gospel concert, and we'd love to have you out. It's a time where we celebrate our community as well as raise support for sickle cell disease. This year, we will be talking a lot about housing. In addition, we do know that our adult retreat and transition camp will be August 12th through the 17th, and the sickle cell walk will be September 7th. If you get the newsletter, you should see all of those things out in the newsletter. But if you don't, please let us know. That is an email that should come out monthly if you're on our email list. We also have a text list that goes out weekly. So I know that many of you probably heard about this session through the text. So if you are not on that text or not on the email, please let us know in the chat and we'll make sure that you get plugged in. We do this work collectively, y'all. We don't do it as in isolation. And so we now have opened up on Tuesdays from 1:30 to 2:30. If you want to help plan all the things that we do, you are welcome to come to our open office time to just help us. You can stop in once, you can stop in every single Tuesday, but we need help to continue to support our community. So this is a way that you can get involved. We also, every third Wednesday of the month, now have Dong Wong, our counselor, who comes in and does the first hour of group session with us as a therapist. You're welcome to come to that. It is a free session to you. And then the second hour, we do all sorts of things depending on the day, what we have planned. So these are ways that you can get involved. There's so many other things I could tell you. January 30th is Spa Day at the Sickle Cell Hub. If you have never been to Spa Day, you should come. It is a time where you can get free massage, free acupuncture, and free reflexology. But more than anything, it is a party. It is a great time to just be in community. I love hearing about the way that resources get shared in that space. If you haven't ever been to Spa Day or you want more information, again, throw your information in the chat and we can talk more about that. Ultimately, we're just here to support you. Sickle cell, we know, we find that those who stay in community do a little bit better. And so we wanted you to know we're here. We will be here. We want to support you however we can. So just reach out if you need anything. And if we don't hear from you, we assume you're doing all right, but you know, you can reach out anytime. Most of you know our numbers, our emails. Anyone on the task force is more than willing to work and talk with you. So with that, any questions about the announcements, upcoming events? All right. And any last questions for Dr. Bender, or just comments you might want to make to Dr. Bender about something maybe you've learned, you've taken away?
And people can always reach out afterwards, right? I mean,
Absolutely.
It's not like this is done. This is life.
Bender, thanks for all the background. It is important that we all know what therapies are out there and what's emerging and what state they're in, because I think that some of them are being presented as cures and when they shouldn't be. But it's important to know what's being brought up and what researchers are working on so that we can be better informed about possible positive therapies for sickle cell, especially seeing that there's been like a 30-year drought on this. So thanks for bringing this up and educating us.
Thank you for the opportunity. It's an honor to be able to have time with you all.
Thank you so much for always being willing to come and talk and supporting us. And this is very informative. So thank you.
Thank you. Kind words.
I just want to say, Dr. Bender, I know you were saying this is very, very elementary and very basic, and we are all mature about sickle cell, but it was really refreshing to see and review, and I really enjoyed it because you presented it in a real good way, and just in it, and it's just a reminder of just even explaining to other people, you know, so it was helpful, and I don't think it was too elementary. It was just refreshing to go, oh yeah, because certain things you just kind of forget about. And so I just want to thank you for that.
I agree.
I agree. Yep, it was great. Great information. Lot to think about.
Yeah.
Lot of more questions that'll come up. So I'm going to take you up on that drink.
And thank you for the kind words. And honestly, one of the problems I have is providers, I think, often forget the basics, that they're so seduced by what's new and coming along that they're so busy looking at what new therapy or thing could be used as opposed to reinforcing heat, bundling up in the cold, hydration, the basics.
Yeah. Oh, you know what? I have a quick question. I lost my computer, so I ran down here with Kendra. So as far as movement, I often think about what are the best exercises for people to do with sickle cell. So, and so some say weight bearing, you say movement. I don't know if you consider weight bearing part of that movement. So with movement, would you say, I sometimes, I'm a worry wart, I'll admit it. I worry. So I like to exercise. So I'm like, okay, maybe I can, get Malik or Deanya on the treadmill for a while. Is how much exercise is okay, or does it matter, or anything goes?
And
or...
the type of, yeah.
No, that's an important question, and there's more and more data about exercise and how helpful it is. And I think it's sort of too big and messy right now to go into detail. But so let me just share a couple of things. When I was saying movement, if it's really in what I was talking about is getting the blood from your fingertips where it lets go of oxygen back to your heart and lungs. Okay. And I think most people know that if you take your hands and you hold them down by your side, your fingertips sort of fill with blood and they turn pinker. If you then stick it and hold your arm up in the air for a long time, they get more pale, right? That's just not as much blood there. Any kind of simple movement like that is moving blood out and back, and it's helpful. So that kind of gentle movement, which you can do in a plane seat while playing video games, kicking your legs, moving like this, all helps. Okay, that's with blood return. In terms of conditioning and being in shape, it is clear some exercise is good. Patients with sickle cell tend to be more resilient than people think. The key is two keys. One is working up an exercise slowly and not all of a sudden saying, hey, January, time to hit it hard, right? And you start slow and build slowly. And that extreme exercise with prolonged heart rate, breathing hard, can be dangerous. And not always, but that's where it's important to work with providers to come up with how you get to that place so that you can do that, but not just sort of jump into that.
Okay, great. Thank you. Yeah, it's always, you hear different things, and so you don't know, but the last thing you want to do is bring harm to somebody by encouraging that, let's go for a long walk, or, and just, yeah. So.
Amna, I think your hand is raised, love.
Yes, I have a question. I don't know if part of this conversation or not. I'm ready these days to receive a newborn baby boy, and we are still worried about, and we know he will be having a 50% chance to have sickle cell or not, but do you have any like information about how many days we should wait to know if he have it or not? Because I refuse to do the blood test. I accept it anyway if he have it or not. So any word, any information, anything support us during this time.
I mean, good luck with the pregnancy, but I'm sorry, I don't fully understand what you're asking.
How many or what the time that after give birth to know if he have it or not have it?
So with the newborn screening, the test they do where they poke the heel right at birth, that usually comes back very fast. If it's abnormal, it comes back faster. So usually people are informed by 2 to 4 weeks. Usually it's 2 to 3 weeks. If it's the disease, not always, but it's usually around like that. They take their time if it's not the disease. Providers, it's the same thing. When the providers are notified, they don't usually jump on it if it's normal. So you can always reach out to providers to look up and get the result to you if you're nervous about that. You know,
Yeah.
especially if it's been after like 3 weeks.
Okay, great. Like the delay it's mean positive things, right? That's what you're saying. Not getting the result.
Yeah.
I'm sorry.
She's asking if the delay, like if it takes longer, the assumption more than likely is that disease is not present.
Yeah, so it's most likely that it's not a problem, you know, but it's good to check because sometimes, especially around the holidays, nothing goes as smoothly as we'd like, right?
Mm. Binder, do they let you know in time, even if it's not disease, is it that they do let you know that it at least is trait? Or they don't?
Oh, I would love working with you guys to get support here. This is no, this is one of the huge problems that I want to work on. Every state does things differently. In Washington state, results don't go to the family. They go to the primary care provider. And then the primary care provider is responsible for giving the results to the family.
Mm.
So and it's paper-based. So, I mean, so much of this is paper-based. And so it is up to the packet and information being taken seriously by the provider and then handed over to the patient.
Mm.
And we know there's times when providers have said, it's not disease, it's not an issue. It can also be a mess because who does the result go to? It goes to the person listed as the provider. And if there isn't a pediatrician or family med primary care doc, it may go to the B. So there's lots of mess ups there. And the state is mandated and is very good at making sure everyone with disease gets that information and gets hooked up.
But it's not in my chart.
That's up to your provider.
Mm. Well, maybe there is some work that we can do together on that to see, because I do think it's important that families are aware if the baby has trait.
Right.
I think there's multiple levels. One is the providers, but I think there's the big thing would be working with the state to change so that results also go directly to the family.
Yeah.
Problem is that is a huge change because it affects every birth, right?
Yeah.
and then got to sort out whether they send results to everyone or only people with traits. And, it's just a huge change. But as big a thing for me is there isn't an investment across the country to make sure people with trait get hooked up with counseling.
Mm.
Right? Because I think everyone should be offered counseling.
Yeah.
And offered a way to have access to those results in the future.
Mm-hmm.
Right? Because honestly, in my opinion, if you're a family and you have a newborn and you're told they've got trait, and you're dealing with all the things going on with having a new baby in the family,
Right.
have one more thing that you don't have to deal with now isn't always the priority.
Right.
Right? So there needs to be a way to come back at it when things slow down and as the kid starts getting of reproductive age and, other things.
Agreed.
Wow.
All right, folks, we have hit the time. Thank you again for everyone coming in on your Saturday to get some education. It sounds like I've seen the chat as well as heard the comments. It's been a really helpful, even going back to the basics sometimes. It's just really, really helpful. Again, thank you, Dr. Bender. Thank you for everyone being here. And we hope to see you all soon at some of the events coming up. Reach out if you have any questions. And like Bender said, this is a continual conversation. So if you still have questions after this call, please email them, text them, and we'll make sure to get them over to Bender. And Dr. Bender, I know you had talked about the ability to share the slides, which if you wouldn't mind emailing them, and then we can send those out in our next newsletter. This was also recorded, so we will add this to our Metro site on YouTube. On YouTube. So if you need to come back and you want to listen again, you are more than welcome. And with that, we say goodbye.
Thanks, everybody.
Well, thank you. Bye.